Welcome to this Give Me 15-minute education program for medical professionals. My name is Jennifer Steerfoss. I'm the CEO of the Steerfoss Consulting Group. This presentation is part of a series covering the final 2014 Medicare regulations. Specifically, this session will address what you need to know about 2014 quality reporting. This session is being recorded live on December 11th, 2013. This session, along with many others, is available for free through iTunes as a podcast or as a video archive on YouTube. Learn more at jensteerfoss.com, including in-depth sessions on the 2014 Medicare final rules. One quick legal note. None of the information contained in this presentation should be construed as legal advice. I encourage you to contact counsel if you have any questions regarding state or federal law that apply to the concepts covered in this session. With that, let's get started. We have a lot to cover in the next 15 minutes, and I'm going to actually skip over a number of items that will be covered in the in-depth session. I apologize for that, but really we can't get into the level of detail I'd like to. So I'm going to give a little bit of legislative history on the PQRS and what we really consider Medicare quality reporting. Also, we will cover the calculations and how that applies future state with other payers, and then I'm going to dig into the Medicare physician reporting along with ASC reporting. So let's start with the history. As you may recall, there used to be an e-prescribing reporting. There was a code that had to be included on claims. It's now moved away, especially as we've moved forward into meaningful use in the EMR reporting systems. But then we have two other systems, the NQF endorsed, which is the PQRS program, and then also ASC measures. There's something called the value-based modifier. And then, again, this is a fun one, is that Medicare is now publicly reporting all of these quality measures and what folks are reporting back to them through their provider directory. So I'll talk just briefly about that. But what we do know is that each of the private insurance plans are doing their own thing on quality reporting, all the way from Excel spreadsheets to very sophisticated web portals that one national payer is offering. And the other thing to know is that Congress really likes this quality stuff. They think it's great. And so this concept is included in both of the legislative packages that are under consideration from the House and Senate. So what I can say is that quality reporting is here to stay for Medicare. And likely as it moves forward and continues to mature, the health plans for the private side are going to move forward and endorse this. So once upon a time, not that long ago, back in 2006, Congress endorsed this concept of quality reporting and something known as the Physician Quality Reporting Initiative. So that was PQRI. They tweaked it a couple years, and then in 2011, they renamed it the Physician Quality Reporting System. So PQRS is the same as PQRI. They just gave it a new acronym because, I don't know, people at CMS wanted to change it. So the thing that I really want you to know is that, again, payment originally started as it was going to be a bonus payment, and then penalties started actually for this last reporting year from 2013 data applying to 2015. So for PQRS, we do have stale data that's being used to determine incentives along with notably penalties. So again, to highlight that. So for the 2013 session, so this last year, really, to be honest, was the foundational year for PQRS. The policies that were used in 2013 are going to be continued to be mirrored in the ongoing years, especially in 2014. So what you experienced this year is what's going forward. So again, the things to note about from 2013, we had 264 measures. And then there was a full year reporting period with a 6-month period for measure registry. Guess what? That's moving forward. So that's something that's exciting and good to know is that the things that were positive in 2013 are moving forward. And again, I've highlighted here for you how the incentive payments work, but I've got a really great chart, so let's get over to that. But before we do, let's talk about the penalties. And this is, I think, the top question I get. How, if I don't report, how are penalties calculated? They take the total of your claims and they're going to apply it to each claim. So for example, just like with sequestration, they look at the total amount that is due, the portion, that 80% that's coming from Medicare, and they reduce it by the penalty. So that's the way the 1,500 claims are done. UBO4 claims, again, it's looking at the conversion factor. So it's not at each claim. Instead, the penalty is applied to the conversion factor for the ASC claims. Notably, 1,500 claims apply the penalty by the NPI that is reported on the claim. And the same is done for the UBO4, but it's by the CMS certification number of the ASC. This is not done by TINs. This is not done by anything else. It is by the individual location or the physician. So keep that in mind because it does get a little bit crazy when you get into it. The other thing, again, I want to spike out, and I mentioned this earlier, is that this is something that is really here to stay, but 2 quick notes that I have from my perspective. Are other health plans, are other entities going to start paying for physicians having an EMR, especially as we've had the meaningful use? The answer is no. And actually, I've heard from senior executives that, to be honest, the money that you're getting from the stimulus bill through meaningful use is more than enough, more than sufficient. And to be honest, they don't see a quality benefit out of EMR utilization. So know that there's a couple states like Maryland that does have an incentive payment if you do have an EMR, but it's a notable thing that most of the health plans are not doing fee schedule bonuses. The same way, what about with medical home and ACOs? The answer is that no, that there's more than enough room within the industry for physicians to not be part of a medical home or an ACO. It is definitely one of the models that Congress is promoting and really pushing forward, and the private health plans are getting more engaged with. But there's going to be a lot of room for different reporting, for different payment policies, for different incentives. So know that this is only going to get more complex as we move forward. And of course, the last note is that physicians hate this stuff. So there was a really great study, if you're ever interested, that physicians really aren't clear on all of this. And so when you look at how their data is attributed to them, most physicians are saying, guess what, it's unfair, and if you're attributing other physicians' work to me, that's not okay. And then when we got into some of the meaningful use aspects and other back and forth, really it was that primary care physicians feel that they have little control over the care provided by specialists. So it's very interesting as we look at the data how this is going to move forward and against some of the attribution issues that have already come up. So let's talk about 2014. Again, the rule came out right before Thanksgiving. It was published in the Federal Register on December 10th. Comments are due January 27th, 2014, and this does apply to the entire calendar year of 2014. What does the rule include? There are 287, and these are called CQMs, clinical quality measures, in 25 measure groups. This is 57 new measures and 2 new measure groups. So I've been spending a lot of my downtime reading this rule and getting comfortable with it. Again, there's a lot of detail in here. So a couple things to know is that for measure groups, there is no longer a claim-based reporting option. I'm going to spike this one out because, again, it's just for measure groups right now. I know that only certain specialties are really using the measure groups for reporting, but you have to use the other options. So this would include registry, this is clinical data, there's a bunch of other groups, ways to report. But notably for incentive payments, so only for incentive payments, the claims-based reporting option is going away. And it is my feeling that that is a true trend, that claims-based reporting for incentives or just generally for reporting is going to slowly move away. CMS does not like this. They want you to use other systems where vendors that you pay for are doing the data aggregation. The next thing to know is that the number of measures for claims and registry-based reporting in 2014, again, this is only for incentive payments, this is not for the cut, has moved from 3 to 9. So it's very significant. There's now 9 measures that have to be reported. They did decrease the threshold, which is great. Before it was proposed to be 80%. That's what had been actually finalized. They revised that. It's now only 50% of measures need to be reported, so 50% of Medicare patients, so that's great. Again, it's one of those, this is a big change. So if you're looking at doing incentive payments and trying for it, know about this. So the incentive payments, I've got a little chart for you on the handouts. The big thing to know about, again, 9 measures. They need to be in 3 domains. We'll talk about what those are. And they need to be reported on 50% or more of Medicare patients. If your practice is unable to do 9 measures, report what you can. And again, report as much as you can. And what will happen is that you will have a MAV review. I'll talk about that in a second. So this is true for claims reporting, registry reporting, direct EHR reporting. If you're doing EHR reporting on individual measures, it needs to be reported for 1 measure where there's at least Medicare data. So again, report as much as you can, but if you can't, you need to report at least 1 measure where there's data for Medicare patients. The beauty about EHR direct reporting that we have right now is that, again, meaningful use is not just Medicare, it's everybody. So if you don't have a lot of Medicare patients, report what you can. Measure groups. This is for registry reporting. 1 measure has to be at least for 20 patients, of which a majority are Medicare patients, so at least 10 Medicare patients, a total of 20 patients. And then clinical data registry. I'm going to talk a little bit more about that, but again, same concept applies. 9 measures, 3 domains, 50% or more of Medicare patients, but you have to report at least 1 measure. And there's no requirement, going back to actually it's not 50% of Medicare patients, it's just as much as you can do. I'm going to talk a little bit more about that. So let's talk about avoiding the penalty. So here's the lower threshold. And it's actually continuing what you need to do today, which is report for the incentive requirements, so what we just talked about, or 3 measures, 50% or more of Medicare patients. That's what's required today. So that, again, a little tweak on that, but if you can't do, again, same thing. If you can't do 3 measures, the MAV review applies, and we'll talk about that. Let's talk a little bit more, too, about EHR direct reporting and registry reporting for measure groups. So if you're doing individual measures through EHR direct reporting and measure groups through registry, you only have the option of meeting the incentive requirement to avoid the penalty. Basically, you have to get the incentive. It's very interesting, different take than they've had in the past, so know about that one. So what are these domains? There are 6 of them. They come from the national quality strategy that HHS has come up with on what they want for reporting areas. So when you're looking at your different categories for those 9 measures, 3 of these have to be met. And they are person and caregiver-centered experience and outcomes, patient safety, communication and care coordination, community population health, efficiency and cost reduction, and effective clinical care. So when you're looking at your codes, you need to have 2 different columns, if you will. When you're building it out, build out your 9 measures, and that they have to be in at least 3 domains. So what's this MAV thing? We've been running into a lot of this recently with a number of my clients. And it comes down to, please, 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 when you're doing your end-of-year review, double-check your electronic EOBs because those electronic remittance advice, also known as ERAs, when they come back, there's a remittance code that you can look for to see whether or not they process these codes. But one of the big things, too, is that the measure applicability, again, if you haven't met the requirements of doing so many codes and so many domains, they're going to review what it is. And I've got the 2013 review up here on my next slide. But there's 2 parts to this test. And it's done by CMS. It's done by their staff. And the first one is making sure that the clinical measures are relevant to your specialty. This is a huge issue because there's so many criteria that really aren't relevant to specialties, but they might be something you're reporting for meaningful use, such as tobacco cessation. So it's really interesting that, again, that's the first thing that they look at, which is why it's much more beneficial just to report 9 measures and 3 domains and meet those requirements rather than going through the MAV. The second thing is looking at the minimum threshold. So the process, again, is done by CMS. It looks at claims-based individual measure reporting. It is when only 1 or 2 measures are reported. And again, it's satisfactorily reported, so meaning that there's a code in there that's relevant and included in the claim and they've received it. Again, what they're going to do is they go in and they look at, is it in a clinically related cluster? And if you're interested, CMS has the clusters up on their website. You can check out whether or not there's a specialty cluster that has been identified for your specialty. And then they're going to look at whether or not there's reportable measures that are sufficient enough. And again, they're looking at whether or not it's for 15 or more patients. So that's really, if you can't do 15 patients, that's where they're going to start saying that there's a problem. So the genius of this is that this applies to your incentives, but it doesn't apply necessarily to the penalty. So know about that. Clinical Data Registry. This is a new one. This came forward in the American Taxpayer Relief Act of 2012. If you remember, it was the fiscal bill year. Excuse me, I've made an error on my slides here. It's for 2013 fiscal bill year. This is the one that was done on January 1st. And what this was is that, and it was actually the American College of Cardiology that was pressing for this, was that they wanted to say that these registries that were sponsored by medical societies would be viable alternatives for reporting. So they have their own measures. These may not be NQF or PQRS endorsed measures. These measures are only ones that are going to be chosen by that sponsor. So likely it's going to be the specialty that chooses them. So in many ways, to be honest, the Clinical Data Registry is going to be more appropriate for specialties where there aren't NQF measures, or again, where claims-based reporting is just going to be too difficult. The data also can include non-Medicare patients. There's no threshold requirement, so it's a really big deal. And the only really big nuance is that there needs to be at least one outcome measure. And so each of the specialties will need to come up with an outcome measure. This is different than a process measure, which the majority of these services in these measures are really process measures. Instead, there has to be at least one outcome measure. So the other thing I want to just briefly touch on is the wonderful headache known as GPRO, group practice reporting. This GPRO option is for what I consider medium to large groups, 25 or more providers, so that's physicians and non-physician providers, like a nurse practitioner or a physician assistant, certified nurse midwife. They cannot be in a shared savings program, so no ACO, no bundling projects, none of those other incentives that are out there. Instead, this is really only for those groups that are not enrolled in the shared savings programs. So a couple things that were new, to be honest. One was that they have aligned the reporting criteria to reflect what could be done if individual physicians were reporting. What I will note is that, yes, they've aligned it, but it's still very focused on what I would consider large system or large primary care entity reporting. The majority of my specialty clients, this isn't really helpful to them because you're reporting on very, very broad measures. But if you are reporting on broad measures because possibly you're part of an MSO or a large IPA or a large health system, this may actually be a really good option. The other thing, too, is that there's a new reporting mechanism for if you're reporting through the certified survey vendors, your CAPS requirements. Again, this is about how your patients feel about you. There's a number of measures related to that about your encounters and engagement and satisfaction. Along with PQRS measures, guess what? You can actually use that survey vendor to meet the GPRO reporting requirements. So that's nice, but again, really broad, usually not something available to most practices or relevant to them either. EHR incentives, a couple of updates there. Again, they added the clinical data registries as a reporting option. The group reporting option, if you're in the CPCI program, guess what? You can also use group reporting, which is another thing. The other little tweak on this is that if you are not using the most recent requirements that have been put forward for certification of your electronic health record, electronic medical record, they're going to say that you need to do attestation. Same way you need to use the most recent measures. There's a couple measures out there that I know have caused some problems, so attestation will be the method to report those measures. I briefly talked about Physician Compare. This is the website where all of the data related to quality reporting will be posted. 2014 data will also be posted. Physicians will have a 30-day preview of what will be put out on the Physician Compare website. This is through Medicare.gov. It's their physician directory. And the reporting threshold will be where data has come back in for 20 or more Medicare patients. Just briefly going to touch on ASCs. There are two new measures that reporting will be required starting, well, actually it started this year, so July 1 through August 15th. This is for the Safe Surgery Use Checklist, and then the 2012 volume of certain procedures. So this one will, again, those are 2 additional ones, and that's affecting payment in 2015. The new one that folks need to be aware of starting October 1st, 2014 is the influenza vaccination coverage of healthcare personnel. I do know that there's been some HR issues that have come up related to this, but that's the new reporting suite for the ambulatory surgical centers and the changes that have come out of the final rule. So with that, you have gotten an incredible overview in a little bit more than 15 minutes, but if nothing else, it's a great crash course for your quality reporting in 2014. Again, there will be more information available in the in-depth session that I'm doing on this one, and registration information is available on jensteerfoss.com. So I hope that you've enjoyed this presentation. For those of you who are listening to the podcast or watching the video archive, please remember to rate this recording in iTunes and YouTube. To receive notices about upcoming Gimme 15-minute programs or other educational sessions, please sign up on jensteerfoss.com. Thank you for joining me for this 15-minute educational program. This concludes the presentation.